Thursday. We have a quiz. We have a little bit of lecture.
No, we don't. We have a quiz this Thursday.
Tuesday.
Is it next?
Until we come back from
Next Tuesday.
Just next Tuesday.
until we come back from Thanksgiving break.
I mean,
Tuesday
we have the
14.
quiz, so I need to- Yeah, let's have
Fired up.
extra credit.
Well, I would just ask this question,
I mean, we
because
can-
I didn't know we had
Can we do an extra one for extra credit?
You know we need it.
Seriously.
Let me take a look at the syllabus.
Next week's hearing on the 28th. I think that's our last quiz.
I think it was
Yeah, but he said we were gonna do it after the exam, right?
It's after Thanksgiving.
Credit.
No, you're absolutely right. Thursday.
Alright, well.
Today is our lab. And Thursday will be our lecture. So you know what? I don't have the, I could probably get the printouts later today, or I'll leave it to you guys. You guys want to do the lab today, or do you want to do it on Thursday?
Thursday.
Yeah, that was really affirmative.
The testing, right?
What's that?
Next Tuesday's the test, right?
Next Tuesday's the test. And we're not doing the lab on the test day.
No, I'm saying it's gonna be due then the day of the test.
Yeah, I'll do it 1 week whenever you guys, whenever it's due. Only thing is I'm thinking about it, like we could do it today, I just gotta go print it and pick it up after class today. But ideally, I want to be able to cover this portion that we're gonna be doing, give you guys time enough to review it, and then by the time we actually do the lab on Thursday, you should already have a good knowledge about it. You would have already heard about it, you would have heard about it today, and then Thursday. Thursday?
Yeah, Thursday. But then, are we doing lab on Thursday or?
We're just doing lab, so we're gonna be doing lecture and lab, no quiz. Just kidding, no quiz. Okay? I was looking at last Thursday, November 2nd.
We'll have none of that, thank you very much.
Whatever, it's all right, I'm catching up. It's good.
That was already got it.
Huh? Well, no, I'm mentally catching up. That's what I'm doing. Okay, so with that actually makes it easier, because then that gives us a lot more time, and makes it a little bit more lax on where I want to be able to stop today. All right, so what we did on last Thursday, we talked about the anatomic background of the respiratory area. We just did a really quick breeze through that area. And what I want to do is just revisit a couple things that I wanted to look at. I want to look at the, do the quick basic divisions. Again, kind of,
So whatever that is,
there we go. So looking at this, we were able to see the functional division, of which we saw the conducting zone as well as the respiratory zone. Conducting zone is going to be something that's going to be of influence later when we look at the movement of air from external air into the lungs. So as we know, lungs obviously participate in gas exchange. The question of it is how much air is going to make it into the respiratory zone where we're going to participate in gas exchange. Gas exchange meaning exchange of air in the alveoli, which is going to be part of our functional unit, as well as the capillaries that are surrounded in there. In essence, how do we extract oxygen, and how do we exchange oxygen and CO2 with outside air? And we know that of the respiratory zone, about 70% of the air is going to be present in the respiratory zone. The other 30% of the air that we breathe in, or that we ventilate, which you'll see later, is going to be stuck in the conducting zone. That's the amount that's actually trapped that won't be participating in gas exchange. So naturally, you're probably thinking, well, what good is that going to do that air is making its way through the conducting zone and actually doesn't participate in gas exchange like it does in the lungs? Well, that's what we're doing when we exchange air. When we're inhaling air, we're going to be humidifying that air, meaning we're introducing water vapor. We're going to be heating that air back up towards core temperature, and we're also being able to filter the air. So that's the whole purpose of the conducting zone. So ways they're able to actually measure the amounts of air, when we look at, we won't really be looking at it in this lecture, but ways they were able to measure the amount of lung volume. Some of the old school ways were just to take cadavers and fill it up with air, measure how much actually fills up the lungs and how much of it actually will fill up the conducting zone. We'll see that a good chunk of where that air is making its way into is in the respiratory zone, of which 70% is going to be participating in gas exchange. And then afterwards, we were able to take a look at the branching off. We went from the trachea over to our primary, secondary, and tertiary bronchi. And what we're doing is splitting up all the way down to the alveoli. So the pulmonary lobule is what we're looking at. The pulmonary lobule is going to contain the alveoli, which is going to expand and fill up with air. And if we measure the amount of surface area, that gives us where we have alveoli, and then we see capillaries surrounding the alveoli. We have about 750 cubic feet worth of alveoli. That's the interface between the capillaries and the external air that's trapped in the alveoli. So we want to increase it, we want to maximize that amount of surface area to participate in what's called external respiration. That's our gas exchange. And all those terms that I'll talk about, you'll be able to see later. That will be able to, that interface that allows us to participate in gas exchange, where we exchange, we're able to pull O2 from the air, and we're able to push CO2 back into the air so that we can expel that out. So that's the interface that we'll be looking at. So later on, what we'll be talking about later today is the air that's going into the alveoli and the blood that's perfusing. Again, that term I'll define later. Blood that's perfusing, making its way into the capillary bed and exchanging gases and then moving back over to the systemic circuit so it can get circulated out to the rest of the body. So it's important for us to realize the movement of air and then the movement of blood around this pulmonary lobule. And then, as I mentioned earlier, we have the terminal bronchiole, we have the respiratory bronchiole, we have the alveoli, and then importantly, we also have this connective tissue that wraps around that pulmonary lobule, which again will make more sense later on. And then with that, we're going to now move in to our common gas laws. Yes?
Can you go over really quickly Dalton's and...
Yep, I'm going to go over that right now. So Boyle's law, these common gas laws, we're going to be visiting these later. But just to recap Boyle's law, which we talked about, Boyle's law comes down to the inverse proportion of volume and pressure. Meaning, if I were to take a water bottle, for instance, and that's filled with air, and it's sealed off, the pressure that's in there would match that of the outside air. So once I close off that water bottle, and if I compress the contents, meaning I'm trying to crush that water bottle, what I'm doing is decreasing the volume, and by decreasing the volume, naturally that's going to increase the pressure in it. So that if I were to increase the pressure in it and then poke a hole on it, you'll see the air is going to be able to escape out. Why? Because there's high pressure inside the container and atmospheric pressure out here. That's going to explain, and when we get into it in just a little bit, we'll see Boyle's law is going to employ how we get air in and out of the lungs. Now, the inverse, if I were to expand a chamber, and in this case here you can see this piston, if I expand that piston, I'm going to double the volume, but at the same time I'm going to decrease the pressure by half. So that's all it comes down to. Now, Dalton's law is just looking at the partial pressures of a particular gas in all of air. So knowing that, as we mentioned, 760 millimeters of mercury is the air pressure at sea level. Again, 760 millimeters of mercury is also equal to 760 torr. We'll throw back to Torricelli, who discovered the whole principle behind this. This was our millimeters of mercury, that long glass barometer that we mentioned on Thursday. And then to take a look at the concentration of a particular gas. So if I'm looking at O2, O2 is 21%. We have 21% of all water molecules in air is going to be O2. And that's our composition of it. And all we need to figure out the partial pressure is to take 21% times that of 760. And that comes out to a partial pressure of O2 at about 160 millimeters of mercury. Now, if I were to take the partial pressure for all the gases in the air, that of nitrogen, that of CO2, that of water vapor, and all the other gases that are in air, When I sum all up those partial pressures, it will total up to 760 millimeters of mercury. So that's how we break it down. And then Henry's law looks at partial pressure in relation to that of gas as well as water. So the best example of that, and we'll be able to compare some of the partial pressures of a gas versus O2, O2 versus that of CO2. We know that CO2 has a tendency to dissolve better in a liquid than it does, than oxygen does. And that's the example that I used on Thursday while we look at carbonated beverages. If I were to take a can, and in that can is a liquid, and I increase the partial pressure of CO2 inside. And that's exactly what they do. Whenever they bottle up anything, they will increase the amount of CO2, and that's going to force more CO2 molecules to dissolve into the fluid. And as I mentioned, once you release the pressure on the, let's say in a soda bottle, if you release the pressure, you're going to release the CO2. CO2 will leave. You'll see the CO2 bubbles rise and escape out of that bottle. And you'll see that all that CO2 that's dissolved in a fluid will start to bubble up and make its way up, and that's the carbonation that you see. That's carbonation escaping that was originally dissolved in the fluid. Did that help? Yeah. Okay. So now what we're going to do is again move into the different components. Pulmonary ventilation is related to the movement of air, while gas exchange we define as respiration, as you can see on this next slide over. Gas exchange that's taking place with the tissues as well as the fluid, tissues as well as the capillaries surrounding, which would be internal respiration. External respiration is us exchanging gases with that of outside air, air that makes its way from the outside and eventually makes its way down to the alveoli. This is gas exchange that's taking place in the alveoli and the capillary interface. Tissue is basically with the capillaries, systemic capillaries, and that of the tissue cells themselves. So this is related to the gas exchange. Ventilation is related to the movement of air. Okay. The other term that I wanted to throw at you is the concept of perfusion. Perfusion is the blood delivery into the capillary bed. So what we're looking at here is the blood that's being delivered by our capillaries, that's by the arterioles, that's making its way into the capillary bed. You're going to have blood that's going to perfuse around that alveoli, and we're going to have air that's being ventilated into the alveoli. So we're going to talk about the coupling of ventilation, again, air movement into the alveoli, and perfusion, the delivery of blood surrounding that area. And the whole idea behind these two is that we want these two to be able to match in order for efficient respiration. Gas exchange should take place. If I have no ventilation, but I have a bunch of blood flowing through, that's a waste because I don't have optimal gas exchange taking place. If I have a good amount of air that's moving into the alveoli, but I don't have any blood flowing through, well, then I have a mismatch there as well, and we'll talk about that in our later slides. And that should top off where we left off. We left off on this slide, which is a throwback to our last cardiovascular side, where we talked about how blood vessels, systemic blood vessels, respond to hypoxic environments, meaning low O2, and where we're going to see vasodilation. Now, on the other hand, when pulmonary blood vessels come into a hypoxic environment, again, low O2, we don't want those. Let me just draw up my alveoli real quickly. And here's our capillary. In a hypoxic environment, meaning low O2 in the pulmonary circuit, we want to, if there's low O2 in the alveoli, we want to be able to reduce the amount of blood flow through the capillary. And that should make sense. If I've got low O2 in this area, I don't want to increase blood flow to that area because this blood will never get oxygenated. So the pulmonary response to a hypoxic environment, the pulmonary capillaries will actually, we'll see a decrease in the amount of blood flow in that area. Remember, we have precapillary sphincters in that area, which will constrict. And that will effectively reduce blood flow down that capillary. So the term that I mentioned over here, vasodilate, that's actually, I want to be able to say, for the precapillary sphincter, that's going to dilate. And just to illustrate that on our tissues, here's our muscle. Here are the capillaries surrounding. If we've got low O2 in the conditions around the muscle, meaning that the oxygen is being used by the muscle very quickly, and now it's churning out excess CO2. And we're also seeing some hydrogen ions, some acids being released due to anaerobic metabolism as a response to hypoxic environments. That's going to want to increase the amount of blood flow through those capillaries. So as I mentioned earlier, those precapillary sphincters, we want them to dilate to increase the amount of blood flow through that area. Naturally, low O2 deliver more blood to that tissue. So we'll revisit this when we come to, and that we'll be able to tie in. This is all part of the auto-regulatory response, meaning this is not necessarily something that our central nervous system regulates. This is local regulation taking place right on the tissue level. So with that, given that we've talked about a little precursor to what we're going to be talking about today, what questions do we have going into? Because hopefully this should be a review, not something new to you guys, because we're going to build up on top of this. Everybody good? All right. So we're not going to talk so much, at least in the first half of today, we're not really going to be talking about the gases, not about O2 and CO2. Really what we want to get into is really going into just ventilation, which is, again, the movement of air in and out of the lungs. We'll first look at how we get air into the lungs, and then later today, the latter half of today, we'll talk about the actual exchange of gases. So with that, let's take a look at ventilation. Ventilation, again, the movement of air in and out of the lungs. And this is how we're exchanging air from the outside environment, bringing that into the alveoli. And when we look at ventilation, about the exchange of air moving in and out, basically involves inhalation, which is the movement of air in, and exhalation, which is the movement of air out. And all of this is going to employ, how do we get air in and out of the lungs? Well, we're going to have to involve changes in the volume. We're going to employ Boyle's law, which is basically going to be compression of the thoracic cavity and expansion of the thoracic cavity to create minute changes of pressure in the lung. That compared to that of the external pressure, the atmospheric pressure, those changes in pressure will allow air to move in and out. The best example I can think of for something like this would be an accordion. You take an accordion, and we're going to be able to change the pressures inside the accordion that will allow air to move in or out. And that movement of air in or out in an accordion is what the audible sounds are made from. So let's take a look at how that takes place, and let's first take a look at inhalation. The whole concept of inhalation, how do we get air into the lungs, is kind of the same way that we look at how we're able to move fluid through a straw. I've got a drink in front of me and I've got a straw. The way I'm able to get fluid into the straw and into my mouth is by creating, I want to say negative pressure, but negative pressure in a sense that it's less pressure that I'm creating. I'm creating a bit of a suction, which is creating lower pressure than that of atmospheric air. So in this case, in inhalation, that lower pressure that I'm able to generate in the lungs creates air that's going to move down its pressure gradient, meaning pressure from the outside, I've got lower pressure in the lungs. Air wants to go in from high pressure or higher pressure down to lower pressure. So that inhalation is going to involve the increase in volume of the thoracic cavity. So let's take a look at the two things that are going to be involved in normal inhalation. The first thing we'll look at is the diaphragm, which is a round muscle, again, right below the lungs and right above the stomach that we'll be able to see later. That's what's going to separate the thoracic cavity from that of the abdominal cavity. And the diaphragm is a muscle that's going to be mostly involved in normal breathing, in what we call quiet breathing. Quiet breathing is what type of breathing you're doing now. The other thing that's going to be involved is a rib cage. Okay? And the rib cage, when we look at expansion of the rib cage, that's going to increase the volume and at the same time decrease the amount of pressure inside. So during normal inhalation or quiet breathing, the diaphragm, when we take a breath in, is going to contract. And normally, it's caged up like this. If I can just sort of draw it out. The diaphragm is normally relaxed. And when we take a breath in, we're going to contract the diaphragm. And that's going to cause the diaphragm to move posteriorly. Okay? And by virtue of that diaphragm moving downward, that's going to increase the volume and decrease the pressure. Again, through Boyle's law. It's just like taking that piston and moving that piston upward. Moving that piston upward will increase the volume and decrease the pressure. And for the diaphragm, in order to, during that quiet breathing, that diaphragm moving, which actually comes out to your diaphragm, only moving about 1 centimeter from here to here during inhalation. That 1 centimeter of movement is going to create about a 1 to 3, and it's not something you really need to know, but 1 to 3 millimeter mercury difference in air pressure with that of the outside. So if it's about 760 millimeters of mercury in the outside air, it's going to be about 757 in the lung. And that difference, 760 to about 757, is going to allow air to move from, again, higher pressure down to lower pressure. And the amount of air that will move in from 760 down to 757, that's going to be about 500 milliliters of air that we're able to inhale. And again, 75% of that due to the diaphragm moving about 1 centimeter down. Not very much. The other 25% is going to employ other muscles. And the other muscles that are involved are the external intercostals. The external intercostals work to basically lift the rib cage up. So expansion of the rib cage, but most of the 75% of the breathing is due to the diaphragm contracting. So again, that's all of us during normal breathing. But what you can do, what we can do is we can employ a deeper inhalation, and that's going to allow us to get more air into the lungs. And how do we do that? Well, we all know how to take a deep breath in. So what I'd like you guys to do is just take a look at your neighbor, look lovingly at each other's eyes. Actually, no. Take a look and try it out. Have one person take a deep breath in, and take a look to see if there's any muscles that you can see that are being employed during a deep inhalation. So pick somebody, take a deep breath in. You see what muscles are being involved? Maybe not, right? So the muscles that are going to be involved during a deeper inhalation, right, are things that need to really lift the rib cage. Which ones do you see? Take somebody who's going to take a deep breath in, you would see the sternocleidomastoids. Okay? Those are the ones that are more prominent on the side, the lateral sides of the neck, and they're going to lift the sternum. Okay, so I need to lift the sternum upward. The next ones are going to be the scalenes. They're the muscles to the side of the sternocleidomastoids, and they will lift rib 1 and 2, and again, lift the rib cage up. The other ones that are also involved, the pectoralis minor, and these are the ones that are not pictured on here. These are going to attach to ribs 3, 4, and 5. And that will, again, lift the rib cage up. So all we really need to do is lift the rib cage up during forceful inhalations. That's where we take a deeper breath in. Like I said, during normal breathing, diaphragmatic breathing, plus the external intercostals to lift the rib cage just a little bit. Take a deeper breath in. We basically need to create more volume, lower the pressure on the inside of the lung, and we employ that through our accessory muscles. Again, the sternocleidomastoids, the scalenes, as well as the pectoralis minor, and then the serratus actually work to lift the rib cage up. So we've talked about normal inhalation, and we've talked about deeper inhalations. Now, exhalation, we can break down to passive as well as forced exhalation. And this is going to be the reverse of what we saw in inhalation, where we need to create higher pressures on the thoracic cavity to be able to force air out. Just like compressing an accordion, we're going to compress the contents. That will generate higher pressure inside and force air out of the accordion. So by increasing the pressure, we're going to decrease the thoracic volume. And the way we do that for passive exhalation, again, passive exhalation is something that, well, I'll ask you guys, what does the term passive mean?
Slowly. Slowly.
No energy? Did I hear that?
Indirect.
So we're not actually using any ATP. There's no contraction whatsoever. It's going to naturally rely on the elasticity, the recoil of the chest. If I've expanded the chest, right, by using active muscle contractions, namely the diaphragm, as well as the external intercostals during quiet breathing, all I need to do, relax the diaphragm. I've contracted the diaphragm, I'm going to relax the diaphragm. I'm going to relax the external intercostals. So compression of the thoracic volume, right, so due to the elastic recoil of the chest wall, I've expanded the muscles, now I'm going to let them naturally relax. Relaxation of the diaphragm is going to now move my diaphragm upward, and that is going to compress what we need in order to contribute to passive exhalation. So that's step number one. There's actually 3 other things that contribute to passive exhalation. Recoil of the chest wall. Number 2, elastic connective tissue surrounding the alveoli. And with that, I'm going to go back to an earlier slide. The elastic recoil of the connective tissue surrounding. If the alveoli are going to fill up, right, they'll fill up, this is going to stretch out that connective tissue. And during exhalation, all we need to do is just let go. And this is going to help squeeze air out from all the way from the respiratory, bronchial, terminal, to the tertiary, secondary, and primary bronchi, out to the trachea, out into the air. Okay, so that's number 2. Number 3, is that drawn on the slide? Here, okay. And then looking at, where am I here? The third is the inward pull from surface tension in the alveoli. And let's see if I have that later on. Let me show you what the alveoli looks like. Okay, there's our alveoli. And notice that the alveoli, again, a bunch of cells, all strung together. And naturally, there's going to be water. Again, those cells bathing in an aqueous environment. We're going to have water that wants to pull towards the center. And that's surface tension. Water wants to stick to one another. Again, due to the presence of the hydrogen bonding, they're attracted to one another. So they're going to help collapse this alveoli. And I got a slide that will go over that on this side right here. Okay? So keep that in mind. We'll revisit that in just a little bit. So that's passive exhalation. Again, not utilizing any ATP. It's just compression of the thoracic volume, natural recoil of the chest wall, the connective tissue surrounding the pulmonary lobule, and then the surface tension that help squeeze air out of the thoracic cavity, back out into our outside environment. Again, that's passive exhalation. The other way that we can get air out is through forced exhalation. In forced exhalation, again, we'll have to employ ATP in order to utilize contraction of our accessory muscles. And in this case, how do we forcefully compress the thoracic volume? Well, 2 things we're going to use. We're going to use the internal intercostals, again, the muscles in between the ribs. All we need to do is squeeze the ribs together. Bless you. And then we're going to employ the rectus abdominis. Those are our abs, and we're going to help pull the sternum down to, again, compress the volumes. So that is forced exhalation. Again, increasing the pressure on the inside to eject air out.
So it does require energy, right?
For forced exhalation, it requires energy. For For passive exhalation, that won't involve any energy at all.
So let's go Valsalva maneuver, would that be voice?
Technically, yes. What we're doing at that point for the Valsalva maneuver is to compress the thoracic volume. Okay? And technically, we're also compressing the abdominal. You're getting your diaphragm to stay in that at that point in time, and you're actually not creating any air in or out. So by compressing the thoracic cavity, what you're doing in compression of it and occluding your breath is to increase pressure. And increased pressure just stabilizes the cavity. All right. So with that, it's a little long. All right. So with that, I want to ask you guys, would you guys be interested in knowing the mechanisms behind crucifixion?
Yeah.
And related to how we can prevent air.
I know it.
It's just warming up, that's all. All right. So most people want to wonder, with crucifixion, something that was employed for a very long time ago. It was actually a torture mechanism to employ that was probably, at the time, the worst ways to die. Okay? And why is that? Why would people die on a crucifix? So crucifix, basically what they would use is a couple boards, and you have somebody on there, and what's happening with somebody who's on a crucifix is that they would actually have their feet nailed to the cross, okay? And they would also have their hands nailed up as well. So now you have somebody that obviously is going to be in a lot of pain. They have the crucifix impaled right through their hands as well as their feet, and they're literally just hanging off. So this crucifixion was employed by the Persians in 300 to 400 BC. Something that Alexander the Great was able to learn from them and use it, and taught Egypt as well as Carthage how to employ this torture mechanism. And they use this, and they reserve this method of torture for the worst of criminals. And if you look at the term crucifixion, when you hear the term excruciating, like excruciating pain, well, that's where you see the prefix of the term. So what they did for somebody who they end up crucifying, again, like I said, they're going to nail areas where we have the highest number of nerve beds. So this is going to be very painful when you stake somebody through their hands and feet. And somebody who's crucified is going to hold on, and in order for them to be able to breathe, they can take a breath in just fine. Why? Because with that, when their arms are abducted, meaning they're separated out, the rib cage is naturally going to expand as well. So air they can breathe in just fine, right? But in order for them to exhale air, they need to be able to compress the rib cage. Okay? So with that, because the rib cage is already abducted, meaning you've expanded the rib cage, for them to breathe out, they would need to be able to pull themselves up to be able to compress the air, to compress the thoracic volume to get air out. But at the same time, they already have their arms pinned, so it's going to hurt them quite a bit, which is going to amplify the sympathetic response. Amplify the sympathetic response, you're going to get them to need to breathe more. What happens whenever somebody's in pain? You hear them. They're going to breathe deeply. So with that, it kind of feeds on its own. So in order for them to get a breath of air in, they'll just relax, breathe in. And then they pull themselves back up, and that's going to cause more pain. And with that, what happens with somebody, so since exhalation is mostly diaphragmatic, they can get air out, they can get a little air out, but the rest of it that they really need to exhale out, they need to pull themselves up. So they actually end up dying of exhaustion. Okay? So that is the whole principle behind crucifixion. And again, one of the worst ones. Another one that I remember seeing, again, one of my late night things that I ended up watching were again, not really related to pulmonary, but they had like the bull. There was like like an iron bull or something like that. And they would place somebody they'd place them into the stomach cavity, and then they would they'd run a fire underneath the bull, and that person would end up like boiling alive in there. But that's not really related to respiration. Yes?
Only if we didn't know, I saw a thing on the History Channel, like speaking of the nerve fibers, so the place they actually pinned, they believe, was like over here.
Mm-hmm.
And something like remarkable about that, I heard for men, it hurts more than women for some reason.
Interesting.
Yeah, it's great. I remember like hearing that, like for men, for some reason, it was like less tolerable in one spot than for women. So that was like a tactic, like you said, for like pain, it's like a pain threshold is much more sensitive.
Yeah. Which makes sense why they would want to employ that. And like I said, if this was one of the worst ways to die, you had the pain from it, you had the impending suffocation that would take place, and then also having to constantly pull yourself up to take a breath, eventually you get exhausted. But you know, the will to survive in something like that, and over time, it's just, you know, it takes a couple days. And it's awful. I haven't seen too many videos on it, but I did read up a little bit on the physiology behind it. Just a little bit morbid curiosity at like 2 in the morning when reading stuff.
Is it like the Salem witch trials when they would put the big blocks of stone on top of the person laying down until they told the truth? Because they would lay stone and give you some time to figure out if you want to admit to being a witch. Another stone, another stone, another stone, and they would essentially die crushed under it, but it's because they couldn't breathe anymore either.
Oh, interesting. If you've got a video, maybe not a video, but like an article. Maybe not a video.
I did see it on the documentary, actually.
It's interesting. Interesting stuff that they did. And even like when we talked about in our, I believe that was our central nervous system lecture, we talked about rat poison. Strychnine was another one. Strychnine was the stuff that affected the diaphragm. So the diaphragm would contract, and that would actually stop the action potentials from the repolarization of the diaphragm. So somebody, or not somebody, but a rat or any animal that ingested the poison would cause contraction of the diaphragm, and then that lack of relaxation prevents them from being able to exhale. So they take their last breath in, and that's really it. And they're paralyzed. They've got that diaphragmatic paralyzation that takes place, and therefore they can't exhale out air normally. And so they die of suffocation. All right, so let's bring it back to normal physiology. Now that we've kind of explored that realm, let's take a look at how we're able to employ the pleura, the lung pleura, the film on the outside of the lung. And the main principle behind pleural pressure is that the pressure on the outside, and the pressure on the outside air is about 760 millimeters of mercury. And the pressure within the pleura, which is that film on the outside. Remember, we've got our visceral pleura, which is right on the outside, and then we have the pleura that's on the outside. And that pleura, and in between is going to be a little bit of fluid that allows friction for the lung to expand. So the idea behind expanding the rib cage to allow inhalation basically means that we're going to employ a lower pressure than that of the inside of the lung and a lower pressure than that of the outside of the lung. That will act as a middleman to expand the ribs, expand the lung itself. So by creating this so-called vacuum, lower pressure on the inside will allow when the ribs expand and the diaphragm contracts, that's going to allow this lung to fill up. And it's not actually really going to touch the rib cage at all. It'll be assisted by the pleural layer. So looking at that, the difference behind, if it's outside 760 millimeters of mercury, we'll see the inside, the pleural pressure is about -4 millimeter mercury difference with that of outside air. So about 756. So if it's 760 here, it's 760 in the inside of the lung, 760 on the outside of the lung. No air is moving in or out, but the pressure is 756 in what we call intrapleural pressure. That's the pressure in between the lung and that of the rib cage. And that allows continual expansion of the lung. If I'm going to now compress the thoracic volume, so I'm going to increase the pressure, again, lower pressure on the inside of the lung, lower pressure than that of the outside of the lung, and there's no actual compression of the tissue itself. We're using the pleural pressure to help squeeze that lung in order to get pressure, or I'm sorry, in order to get air out of the lung. So looking at that, and I'm not really going to go too much into pleural pressure because I don't want to lose you guys too much, but in order to get us to do normal quiet breathing, it comes out to about ½ liter of air. So looking at the volume of air, the volume is not necessarily 0 in the lung, but starting from the bottom of a normal breath to the inhalation of a breath. Upwards, moving upwards is going to be inhalation. Downwards is going to be exhalation. And again, looking at the middleman in between, we want to be able to look at the changes in pressure. When we're inhaling, pressure is going to be lower in the thoracic volume. So intrapulmonary pressure is the pressure inside the lung. It's going to be lower than that of atmospheric air. And for us to exhale, pressure is going to be higher in the lung in order to get air out of the lung. So that should make sense by now. And this line versus this line should help explain inhalation and exhalation, rather than as a whole how ventilation works. But looking at that, we're going to see our pressures from 0 down to -4 for our pleural pressure. And the pleural pressure, again, helps during inspiration. So inspiration, you'll see it decrease as well, so it moves along with it and helps the lungs expand. And then when we expire, or when we exhale, we're going to move that pleural pressure back up, and that's going to help compress the volume. So really the only thing that just to kind of help simplify things, is really that this X, like middleman, is filled with fluid to help create the slipperiness of it all, and helps expansion of the lung without actually touching the rib cage. So this is important because the pressure, like I said, in the intrapleural pressure is lower to help assist in the expansion as well as the compression of the lung. Because what happens, and this explains it all for you right here, and in reality, I'm not going to ask you guys about the transmural pressure in between. I just want you guys to recognize that it's lower in the intrapleural pressure than that of the intraalveolar pressure. Looking at what happens in what's called pneumothorax. And you probably, if you're in the medical field already, you might be familiar with the term pneumothorax. But basically what it comes down to is the inability for a lung, one of the lungs, or both for bilateral pneumothorax, the inability for the lungs to expand. And that's due to a puncture of the pleural space. Again, the pleural space being the intrapleural region. So if it's supposed to be negative on the inside, any puncture by a broken rib or an object that comes in and punctures that area will create a normal pressure in there. So basically what's happening is air is starting to leak in. If it's 760 millimeters of mercury on the outside, and it's supposed to be 756 millimeters of mercury in the pleural space, a puncture would cause air to move into that wound. And so what that's going to end up doing, now you're going to get air moving in, you're going to see that the lung cannot maintain its fully expanded form. Why? Because now technically it would be about 760 millimeters of mercury in that area. Now it's 760 in the lung. And any movement of the rib cage will cause compressions that will start to deflate the lung. And as we deflate the lung, we're going to get air moving in and continually filling up that space. So that pneumothorax can present as an issue because now we can't expand that lung fully to allow for maximal ventilation. So typically you'll see the symptoms. Shortness of breath are going to be a common symptom, and obviously chest pain in that area due to the inability of the lung to expand, and also that of the puncture wound itself. So typically what we would do in order with anybody that presents with pneumothorax, depending on the grade of the pneumothorax, how severe the pneumothorax is, with minor cases of pneumothorax, somebody can be supplemented some, obviously if they plug the hole, allow the membranes to heal, they can supply supplemental oxygen to somebody, and eventually that should be enough oxygen for them to be able to extract as much oxygen from the air. And then also over time, we're able to start absorbing some of that air that's in the affected area. Now, in other cases where we have higher grade pneumothorax, that's where they can actually use a vacuum or a chest tube or a syringe to help extract that air out. So extract that bubble of air, move it out, and then seal the wound, and eventually over time that should heal and that pneumothorax should subside. And you can see that what that looks like right underneath. They can puncture a hole and suck out the air, and that will help expand the lung once again.
In the military, they use pens in that situation.
Do they?
Yeah.
So it's just like a
They
like
go
a.
out the intercostal space and actually put a pen in there, like it's like a pen. They pull out that piece and it allows the lung to inflate because it releases that pressure.
Yeah, I've heard of some of the things that they can do too. Is like they can once they puncture, they can get somebody to really squeeze the air out, and that'll help expand and push air out. And then they just plug up the hole, and eventually they can resolve that. And now that person, when they're normally breathing, should allow the lung to fully expand. So those are the other techniques that are in place. These are things that take place in a hospital setting. But it's interesting to see what they do in military cases. Some of the things that, and not too much that I've been able to see, but some of the things they can do in life or death situations, especially when there's limited resources. All right, so that explains what's happening, again, with our inhalation. We've talked about inhalation, we've talked about exhalation, and naturally what we're going to be doing next is to take a look at what's happening on a cellular level. Other factors that affect ventilation, as I mentioned earlier, one of the things that contributes to passive exhalation is the inward pull from the surface tension of the alveoli. So with that, we'll take a look at this image right on the bottom right of your slide. This will show you the capillaries surrounding the alveoli, and then this will be the alveoli itself. And from here you can see our simple squamous cells, epithelial cells, made by our type 1 alveolar cells. And since these cells are bathing in an aqueous fluid, we'll know that there's this water, or layer of liquid, surrounding the inside of the alveoli. Now these water molecules want to constantly pull on one another, so there's this constant pull with all the water molecules on the inside. And all that pull, when we look at where the force is being applied, water wants to pull towards the center. And if you don't believe me, like I said, take a Ziploc bag, add a little water to it, and watch the Ziploc bag hold together very tightly due to the water tension, the surface tension of that water. The cohesiveness of the water molecules hold those two layers of plastic together. Now, with that, that's going to prevent the stretching of the alveolar wall, because what we want in order to get air into the alveoli is to expand. So we need something that negates, or not negates, but counters the effect of that surface tension. So what we employ is what's called a surfactant, and the surfactant is produced by our type 2 alveolar cells. So we get these surfactants that help space out our water molecules. And that reduces the amount of cohesiveness between the water molecules and less of that surface tension that wants to pull it together. So in effect, our surfactant helps reduce the amount of alveolar collapse that takes place due to the surface tension of water. And that should make sense. We don't want our alveoli to flatten out completely, because if they do, how do you fill them back up? We need the surfactant to help prevent the alveoli from fully collapsing. So this ties into the process of production of surfactant. Surfactant on its own is a protein. And this is actually what contributes to the death of newborns. Okay. So about 1% of newborns have a condition called infant respiratory distress syndrome, IRDS. Infant respiratory distress syndrome. And it's the deficiency in the surfactant. So no surfactant being made, and this is something that you also see in premature babies as well. The lack of surfactant causes the alveoli to collapse due to the impending surface tension. And it might be due to the lack of surfactant. It could be to an enzyme that breaks down the surfactant. It could be due to a genetic condition where infants can't produce the protein or surfactant that helps counter the surface tension, and will lead to, is actually a leading cause of death, especially for premature infants or premature newborns. So with that, there are ways to get surfactant back in. I haven't looked too much into it, but I know there are artificial surfactants they can use that will help temporarily open up the airways. They can also employ, for preemie babies, you can see them in what are called, they're like incubators. They're positive pressure chambers that they'll keep them in. So they've got a little chamber like this, and there's your little baby on the inside. And what they do is increase the amount of pressure on the inside. So they're in a high pressure environment, and that helps the alveoli remain open while they're able to get surfactant in there, while they can start generating some surfactant to help counter the effect. Okay? So that's kind of what they do. Now that's exactly what they do in premature babies. Other things that we can take a look at that will also affect ventilation, things that happen outside of normal functioning lungs, is to measure lung compliance. And this compliance is basically a measure of the stretchiness of the lungs. How stretchy are the lungs on their own? And they should be, given the makeup, the tissue of the alveoli, they should be able to expand. So this compliance is the inverse of stiffness. The way something is a little bit more compliant, it's more rubber bandy, as opposed to stiffening of the lung, which will prevent the lung from expanding. So let's take a look at cases where we have decreased compliance, or in other words, increased stiffness. So a decrease in compliance means less stretchiness, means stiffer lungs. And what could cause stiffness? Fibrosis of the lungs, so pulmonary fibrosis, where pulmonary fibrosis can create scarring in the lungs itself that will prevent the lungs from expanding. You'll get pulmonary edema, which is a buildup of fluid around the alveoli. And then paralysis of the intercostal muscles, meaning the intercostal muscles are stiff and prevent the thoracic cavity from expanding. So the best way to exemplify decreased compliance or increased stiffness, in medical school what they do is they take those, have you seen those bands that people are using around their stomachs? It's supposed to be for like body shaping. Anyway, I'm not going to really talk about that, but what they can do is they can wrap it around the lungs. And that's supposed to mimic decreased compliance or pulmonary fibrosis. It's the inability for you to be able to fill your lungs up. So you're going to affect the mechanisms involved in quiet inhalation. Now the other side, is the exact opposite, is increased compliance. So lungs that are way too stretchy and decreased stiffness. And the classic condition for this is emphysema. So emphysema that's, in almost all cases of emphysema, are due to cigarette smoking. And that causes breakdown of the alveolar walls. So here you see what healthy alveoli look like. They're small, filled with air, and the surface tension helps close that alveoli. Now the breakdown of the alveolar walls causes less recoil of the alveoli, causing what's called trapped air in the lung itself. So with the lungs that are able to expand normally, they have a hard time squeezing air out of their lungs due to that decreased stiffness. And the way you can mimic those of what it's like for somebody with decreased stiffness is to literally take the straw and tell them to exhale through that straw. They have to work on active exhalation to help squeeze and compress the thoracic volume to push air out of their lungs. So all of this comes down to whether you have decreased compliance or increased compliance, whether it's pulmonary fibrosis or emphysema, all come down to decreased ventilation. That is a decrease in the amount of air you can get in or out of the lung. So typically the symptoms that are exhibited by people with either of these mechanisms of disease come out to shortness of breath, decreased quality of life, and so forth. So so that's a factor that comes down to the tissue makeup, and that's a dysfunction of the alveolar tissue. The other factor to look into is airway resistance. So instead of looking at the respiratory zone, let's take a look at what happens in the conducting zone, airway resistance. And the way we can measure airway resistance, and remember, if pressure is related to the resistance times the flow, just like we saw in our vessel lecture, we can look at movement of air. Instead of liquid moving through a vessel, we can look at air moving through a vessel. And the idea behind airway resistance is that we can see the amount of flow, which is the atmospheric pressure, that's the pressure on the outside of the lung, and the alveolar pressure, which is the pressure on the inside of the lung. And if that remains normal, and we start to see an increase in the resistance, that will decrease the amount of airflow into the lung. And as we mentioned in our vessel lecture, resistance, actually I don't even need to write it out because I've got that listed out for us on here. The resistance is proportional to the inverse of the radius to the fourth power. As I mentioned in our cardiovascular quiz, the thing is that that's going to affect the amount of fluid, whether it's air or an actual liquid, moving through a vessel, is going to be related to the radius of the vessel, here up to here. So we can employ bronchodilation and bronchoconstriction, naturally the smooth muscles surrounding the vessel, to adjust the airway resistance. So as I mentioned previously, breathe through a big boba straw versus breathing through a coffee straw. And if you notice, breathing through a coffee straw is much more resistant. It's hard to get air out breathing through a coffee straw than that of a boba straw due to the change in the radius. A change in the radius is amplified by 4 times its amount. And with that, let's take a look at the pathophysiology of asthma. So the first characteristic of which we talked about with asthma and asthmatics is the smooth muscle walls surrounding the airways. So here we're looking at a bronchiole. You can see the smooth muscle, which are the darker purple bands. These are the smooth muscle rings that wrap around the airways. And we can bronchoconstrict to allow more air in. Bronchoconstrict to reduce the amount of air going in, or we can bronchodilate to allow air to move, more air to move in. So in the cases where in somebody who is an asthmatic is going to, we're going to need to employ a beta agonist. And remember, epinephrine that comes in, the sympathetic pathways that lead to the smooth muscle wrapping around, will end up relaxing the smooth muscle walls. So what we want to do in the case of somebody who is an asthmatic is to give them albuterol, because albuterol will relax the smooth muscle walls and open up the airways. In other words, reduce the resistance of the airways. So by bronchodilation, which is going to dilate the bronchioles, will allow air to move in naturally. The other aspect of asthma is to look at airway inflammation. And airway inflammation is due to the epithelial cells on the inside that will get agitated and create a good amount of mucus. And that mucus on the inside, inflammation of the epithelial cells, will cause inflammation inward. So here you can see the contrast between this cross-section here where the epithelial cells are normal, and then here you can see what happens with the effect of inflammation. It starts to build up and constrict the area that allows air to move in. So this effectively increases the airway resistance. And on top of due to that irritation as well as the inflammation that takes place, you're also going to get mucus that builds up as well, effectively reducing the amount of air traveling through. So here you can see the comparison of the radius of air passing through this airway and over here where air is passing through this airway. And you can see that this is going to severely reduce the amount of airflow into the lung. So typically what they do with people with asthma is to give them a beta agonist like albuterol. Albuterol typically only works for about 20 minutes to an hour. So they want to give them what's called a long-acting beta agonist, a LABA. That's going to help with the smooth muscle around the airways. The other component that they would give them is a corticosteroid. And the corticosteroid is going to be an anti-inflammatory. It's going to work to reduce the inflammation in the airways to bring this back to look like it's supposed to over here, and then also reduce the amount of mucus. So typically in this case, they would give fluticasone. So LABA would be something like Ceravent, and again, you don't really need to know these names. Ceravent being that long-acting beta agonist, and then fluticasone, which is going to be the inhaled corticosteroid. So those will mitigate the effects of airway disease, and the combination of these drugs, Advair, the big purple discs that you might see people take. And they're a disc that you can turn and you inhale, and it's usually a combination. It's a combination, a form of combination therapy to tackle the airway resistance from both of these mechanisms. So this image right here, which is available in your slide, I believe you should be able to see it in your on the full slides. I'll see if I can grab this image and also put it in our Google Drive. That way you can go in and really zoom in and take a look at the entire system, everything from our conducting zones all the way down to our respiratory zones, which is going to help help you visualize and help you conceptualize all the mechanisms for ventilation. With that, we've looked at ventilation, both inspiration as well as exhalation. We've looked at the other factors playing into effect, the tissue makeup, and then looking at what happens from a physics standpoint regarding the radius of the vessel for airway resistance. Okay, what questions do we have about that? So with that, now I want to go in and looking at the last you guys want to take a little break?
Sure.
Yeah. How long? 5, 10, 1 minute? 5 minutes, 10 minutes?
1 minute. Until next Thursday.
5 minutes? All right. I'll give you guys 5 minutes to get up and stretch, do what you need to do, and then we're going to move into lung volumes.